Our next speaker comes to us from right around the corner here in Dallas, Dr. Stanley Cohen, one of my mentors and favorite rheumatologists. Stan's a leading author on most of the major trials done in rheumatology. We've asked Stan, and Stan is at UT Southwestern and Rheumatology Associates here in Dallas. We've asked Stan to talk about, this little-known area called JAK inhibitors.
You've been living under a rock, it's a little-known area.
What's that, Stan?
You've been living under a rock, it's a little-known area.
There you go.
Right.
Stan.
All right, well, thanks. I appreciate it. Thanks for having me, Jack and Artie. And so, I've given you a handout which has probably 40 more slides than we have here today because Jack gave me 12 minutes to talk about it this morning. But this is an area I've been interested in for a long time. I did my first study with JAK inhibitors in 2006 with tofacitinib. And so I was off the bat, it was clear that these drugs are very effective. But I was concerned about safety and continue, to have concerns about safety, as we all do in practice as we prescribe these for our patients. These are my disclosures. I'm a clinical investigator. Our CRC still exists. We're struggling to find patients, but the science of healthcare has never been better. The delivery of healthcare has never been worse. But certainly if you have patients with scleroderma, Sjogren's, refractory dermatomyositis, we have wonderful trials ongoing presently. So first question, I think this is for the audience. Preclinical Janus kinase isoform specificity is associated with differences in efficacy and safety with the individual JAK inhibitors. True or false? I'm only going up to 70, so I don't run out of time. Oop. Twice. All right, we'll see the trend, and we'll talk about that a little bit as we go on. Which of the following indications are JAK inhibitors not yet approved for? Axial spondyloarthritis, psoriatic arthritis, Crohn's, or ulcerative colitis? Oops. Waiting on the... But it's about to be. Upadacitinib is about to be approved for Crohn's disease very shortly at much higher doses than we use in RA, which is going to be very interesting from a safety perspective. So the JAK-STAT pathway was worked out around the turn of the century, and exquisite work showed that type 1, type 2 cytokines, which does not include TNF, does not include IL-1, various growth factors, cytokines of both the innate and adaptive immune system signal through the receptor, but require the Janus kinase enzymes to phosphorylate the intracellular portion of the receptor, which then will upregulate STAT and lead to transcription of cytokine genes in the nucleus. And these are pleiotropic, multiple cytokines are impacted by this pathway. You've all seen various depictions of this slide. We have, JAK, and these JAKs signal in pairs, JAK1, JAK3. JAK1 can signal with TYK2, JAK2 as well. Originally, it was felt that blocking both JAK2 would be lethal. It certainly was in animals, but it turned out that you could block JAK2 along with JAK1, TYK2, and so forth. So there's different cytokines. IL-6 is a very important cytokine, which is inhibited by Janus kinase signaling, blocking signaling. IL-12, 23, you can block interferons, type 1 interferons, so attractive target possibly for lupus. We also know that inhibiting TYK2 is clearly effective with deucravacitinib in psoriasis. So multiple therapies have been developed based on this knowledge of the JAK-STAT pathway. This slide ran out of time. I couldn't figure out, I'm not as good as Jack with slides, I couldn't figure out how to get 2022, 2023 on here, but basically what you have is the growth of the JAK inhibitors over the last decade from 2012 on in rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and ulcerative colitis, and now we'll be adding Crohn's for upadacitinib as well. So these drugs are very effective and rightfully so have been approved for multiple indications. These are the JAK inhibitors which have been approved for other IMiDs, immune-mediated inflammatory diseases, or either under development. Deucravacitinib is now approved for psoriasis and there's phase 3 trials for psoriatic arthritis. It's in clinical trials for Crohn's. TOFA trial was terminated due to lack of efficacy. Multiple therapies for atopic dermatitis. It's amazing how well we've done with a really troubling syndrome which we've had to deal with in the past. In lupus, baricitinib, we know the phase 3 trials failed to show efficacy, where phase 2 was successful. upadacitinib and deucravacitinib trials are ongoing in lupus. JIA, tofacitinib is approved, and then Barry and upadacitinib ongoing clinical trials. And this list changes day to day, so this may not be totally up to date. Alopecia areata universalis, baricitinib has now been approved. Other clinical trials are ongoing, vitiligo, and then we are participating in a clinical trial with refractory dermatomyositis with a JAK1 TEC3 inhibitor. There's been investigator-initiated trials in Sjogren's, and I just was yesterday got an email about a trial with one of the JAK inhibitors in Sjogren's, which actually is a pharma-sponsored trial. Preliminary work Dinesh Khanna did in scleroderma suggested in a very early study there may be some benefit. Giant cell arteritis, Takayasu arteritis, there have been investigator-initiated trials, the autoinflammatory syndromes, uveitis, and we know about the emergency use authorization for baricitinib in COVID. So this is a busy slide, and again, in all of the clinical trial programs, the JAK inhibitors, each one of them, and there's actually 5 of them. We have 3 of them on the market in this country. Filgotinib is in the rest of the world. Pepacitinib is in Asia. And they all took on adalimumab in the clinical trials. And for the sake of time, I'm just going to, because this is really the 40,000-foot view, they all were successful. Each individual Janus kinase inhibitor was effective as adalimumab, or in some cases, with certain clinical outcomes, superior with baricitinib and upadacitinib. But clearly showed that we finally had, after many years, the efficacy with a small molecule that we have with biologics. And Artie and I and others in JAK who did clinical trials, we spent about 20 years with other small molecules trying to emulate what we saw with TNF inhibitors, and we had failed until the JAK inhibitors were approved. This was a study looking at patients who were failures or incomplete response or intolerance to biologic DMARDs. And this was upadacitinib, the approved dose, 15 milligrams, versus abatacept. And what you can see here is that the upadacitinib was superior in the delta and the DAS28 CRP at week 12, which remained statistically different in week 24, although the numbers narrowed. Abatacept is somewhat slower onset of action. And again, in the more higher threshold hurdles, as well as the ACR responses, looked like upadacitinib was better or same in most of these as well. And again, a tougher population of biologic experienced patients. So again, clearly showing benefit. This was in psoriatic arthritis, didn't show up that well, but this was 15 to 30 milligrams of upadacitinib. 30 milligrams was not approved, and we'll show you reasons why in rheumatoid arthritis, psoriatic arthritis, but clearly showing very similar efficacy to adalimumab compared to the placebo in the bottom, and again, showing a significant efficacy in this particular immune-mediated inflammatory disease. And then, again, these slides are in your handout. This is deucravacitinib in a phase 2 randomized clinical trial recently published in lupus. And what you have is the week 32 endpoint, and then week 48, if I'm reading it correctly. And going left to right, you have the SRI-4, which is one of the standard criteria now. And all doses without a dose response. There is no dose response between the 3, 6, and 12 milligrams of deucravacitinib, but basically superior to placebo. And on this portion of the slide, you can see actually a drop in anti-double-stranded DNAs, complement improved. And this may have to do with the type 1 interferon signaling through TYK2 that's being blocked. There may be other MOA, but it certainly may be playing a role. So as far as efficacy, I think it's clear that JAK inhibitors work in multiple IMiDs with similar and comparable efficacy to TNF inhibitors. There were some studies with UPA and baricitinib showing statistical superiority to adalimumab plus methotrexate. Small numbers of patients, clinical significance is unclear, but clearly they all work. We showed you the data from select choice, upadacitinib statistically superior to abatacept in biologic experienced patients. Psoriatic arthritis effective. We're not showing you data in early RA. The JAK inhibitors were superior to methotrexate in methotrexate naive patients, but clearly that's not available for us to use at this point, but maybe in 3 or 4 years when one of the first JAK inhibitors becomes generic. Despite preclinical data, whether it be biochemical data, cellular data, suggesting different JAK isoform inhibition, with the different therapies, and there's a lot of flaws in those assays depending on how much drug you put in, how much substrate you put in there. Efficacy results are comparable, so there's really no difference as far as efficacy between the various JAK inhibitors and which particular isoforms preclinical data suggested they inhibit. In the latest recommendations from the ACR, as far as treatment recommendations, we elevated JAK inhibitors to the same status as biologics after CS-DMARD failure, but then we retracted that after some of the safety issues, which we'll discuss in detail, came out. What about real-world studies? There's been some publications, presentations. This is the JAKPOT study, which, depending on the publication you read, is 16 international registries or 18 international registries, and they looked at comparative effectiveness of JAK inhibitors basically by retention on therapy or survival on therapy. 25,000 patients, about 6,000 on JAK inhibitors, the majority on TNF inhibitors, and what they found, as you would expect with a new drug, patients with JAK inhibitors had higher CRP, higher disease activity, had failed more previous targeted synthetic or biologic DMARDs, and of interest, and we know that about 50% of people on JAK inhibitors are on monotherapy without methotrexate or other CS-DMARDs. And what they found in following the patients over 3 years, about a median of 2 years, is that basically retention rate on JAK inhibitors was similar to the other biologics. And, you know, some would argue, well, that's the last drug we have available. That's why we're going to continue them on the drug. But there's certainly not a significant drop-off over time compared to the other more aggressive therapies. And then they recently looked at the question of, can we cycle JAK inhibitors? There are no clinical trials that look at cycling from one JAK to another. And they had 365 patients who cycled from one JAK to another, either for lack of efficacy or intolerability, or switched. And again, what you can see, sort of like Kevin's unfortunate hydroxychloroquine curves, these do overlap. So there really was very little difference. Patients seem to do just as well switching or cycling. So certainly I think we all do that in the clinic and try to see if we can salvage a patient who's failed one JAK inhibitor. So let's talk about JAK safety. In the oral surveillance clinical trial, which type of malignancies were not seen more often with tofacitinib compared to TNF inhibitors? Breast cancer, lymphoma, lung cancer, or non-melanoma skin cancer? So the answer is correct. Breast cancers are actually seen more commonly in that particular trial with TNF inhibitors. Which patients with the greatest risk of MACE will have the greatest risk of MACE events in the oral surveillance clinical trial? Patients with pre-existing cardiovascular disease, patients with type 2 diabetes, patients aged 50 to 65, or a family history of cardiovascular disease? That's correct. Pre-existing cardiovascular disease. I'll show you that data. So the safety of JAK inhibitors has been well delineated, and these things that we always concern ourselves with any therapy: serious infectious episodes, opportunistic infections. We know JAK inhibitors are an outlier with an increased risk of opportunistic infections, primarily herpes zoster or other viral infections. So we want all our patients to be vaccinated after they have a diagnosis of inflammatory arthritis, start methotrexate, and so forth. Malignancies are concerned. Hematologic, we see occasional anemia, leukopenia, lymphopenia, which we monitor. Transaminitis occurs with all of our therapies. For some reason, there's a very minimal, generally non-clinically significant increase in serum creatinine. I've got a couple of people I've had to take off JAK inhibitors for that reason, and occasional increase in CPK. Jack keeps tweeting about acne in the clinical trial, so I had to add it. It wasn't on my slide previously, but certainly seen in the atopic dermatitis trials and with deucravacitinib. We know the lipids are elevated probably due to IL-6 inhibition, and that was one of the reasons the oral surveillance trial was conducted. And then GI perforations, again, possibly related to IL-6, so we're careful in patients with diverticulitis. And then we'll talk in detail about venous thromboembolism. So this is a paper we published years ago looking at 23,000 patients on tofacitinib. This was everyone from phase 1 on who went into long-term extension trials. Looking at the adverse events of special interest, you can see the serious infection rate was 2.5 per 100 patient years, herpes zoster 3.6 per 100 patient years, which was certainly increased over what we see with other biologics. And then the other adverse events, which really fell well within the spectrum of what we've seen with biologics in the past. The good news is when you take a look over time, over the months of follow-up, these incidence rates did not increase for serious infectious episodes. They remained stable. That's what you want to see long term. This is baricitinib, and just again 14,000 patient years, long-term data March 2022. And again, really nothing different from other JAK inhibitors. Still the herpes zoster signal. The rate of VTE was what you would expect. MACE 0.5 as well. So nothing unusual here for JAK inhibitors. I do want to point out, and this is one thing which we're still getting our hands around. In the past, doing clinical trials for 40 years, we never really... Okay, thank you. We never really looked at safety as far as statistically different, and we still don't. But when you look in your handout, you'll see that with the 4 milligram baricitinib dose compared to 2 milligrams, that numerically there's an increase in adverse events down the whole panel at the higher dose compared to the 2 milligram dose, which is part of the reason the US FDA did not approve the 4 milligram dose here, which is approved in the rest of the world. This is upadacitinib, and again, looking at the various adverse events, and what you can see in general, the adverse events between adalimumab, methotrexate, which were the comparators in the phase 3, and these were the phase 3 program, were very similar except for zoster. And then the 30 milligram dose seemed to have the greatest risk of adverse events, and that's why it was not moved forward, because there was no additional efficacy with the 30 milligram dose compared to the 15 milligram dose as well. When you type at the bottom right, you can see VTE really well within what we expect to see as far as VTEs. And this is just looking at other adverse events of special interest. Transaminitis, really no significant difference. CPK elevation was different for the upadacitinib group. And then in that study I showed you the head-to-head comparison of upadacitinib and abatacept. Abatacept is in the little orange balls, and the triangles is upadacitinib. And what you can see in general as far as the percentage of adverse events in this short-term study was greater for upadacitinib than it was for abatacept. And this might reflect the relative safety of abatacept, which we've known to love, and then again the quirky side effects that we see with JAK inhibitors. It was also clear from data that I haven't shown that there's a very narrow threshold of dose-related toxicity with these JAK inhibitors. And we learned that very early on in the studies, phase 1 and phase 2 studies. So it's not surprising that the 8 milligram dose of baricitinib went away, the 30 milligram dose of upadacitinib, at least in inflammatory arthritis, went away, the 10 milligram BID dose of tofacitinib went away because of toxicity issues. So this is, again, in your handout, and basically is looking at the VT instance rates in various observational databases. Some were clinical trial databases, some were claims-based databases, but the numbers vary, but it's somewhere between 0.5 to 1.5 per 100 patient years. This was a meta-analysis looking at 42 clinical trials, which 29 were inflammatory arthritis with JAK inhibitors compared to placebo. And basically the bottom line, the pooled instance rate ratio of VTEs was 0.68 with the confidence intervals crossing 1. So their conclusion from this article was the JAK inhibitors are not associated with venous thromboembolic events. So the fly in the ointment began in actually the placebo-controlled trials with baricitinib, where there were 5 patients who had VTEs, all with risk factors for VTE, compared to none on 2 milligram baricitinib and none on placebo. And this raised the question at the FDA. And then follow-up, there really was no increase seen in the long-term follow-up studies, but again, the FDA was concerned about this data. And over time, you can see here that the incidence rates remain stable. There's so few patients in the last greater than 336, so I can't really judge that category at that time. So let's talk about oral surveillance. This was a mandated trial by the FDA based on the 2 things. One, the lipid increase noted with tofacitinib, and then in the long-term extension trial, there was an imbalance in malignancy and serious infectious episodes with the 10 milligram BID dose compared to the 5 milligram BID dose. So the study was mandated, and there was 5 milligram BID of tofa, 10 milligram BID of tofa plus methotrexate compared to adalimumab in North America plus methotrexate or etanercept. And patients had high risk for coronary outcomes, cardiovascular outcomes. They had to be over 50 years of age. Primary endpoint was non-inferior tofacitinib regimens to TNF inhibitor. Control regimen will be concluded if the upper confidence limits for both malignancy and MACE are less than 1.8. And this confidence intervals were taken from the diabetic trials looking at cardiovascular risk with drugs for diabetes. So to summarize here, this was an enriched population for cardiovascular outcomes. They were 10 years older, mean 10 years older than the patients in the randomized clinical trial program that resulted in approval, and 11% of patients had already had coronary artery disease. And so again, it was a difficult population. So if you look here and just compare, this is an algorithm looking at cardiovascular risk over the next decade. You can see in oral surveillance already 11.4% of patients had coronary artery disease. Many more patients had high risk, in contrast to the clinical trial program shown there that where most of the patients had low risk or mild risk. So what was seen in year 4 of the study, 2019, was an imbalance in pulmonary embolism and a trend for DVTs. And that data is shown here with the 10 milligram dose, where actually it was statistically different from the TNF inhibitor, which led to a removal of the 10 milligram cohort, and all patients went on 5 milligrams who continued in the study until completion. And again, this led to more sub-analyses which show that the highest risk of developing a VT and the greatest hazard ratio was patients who had had a previous VTE, patients who had active disease, and so forth. So again, warnings came out from the EMA, the FDA, and that we wanted to use caution in using these medications in people who are at risk for venous thromboembolism. A recent study, real-world experience, this is from the Swedish Quality Registry, which was recently published, which is fascinating, and they took all patients from 2010 to 2021, either starting biologics or going on JAK inhibitors. And what you can see in the middle here, which is the most disturbing, and 78% of patients were on baricitinib, 18% on tofacitinib, and only 4% on upadacitinib. They did not look at the upadacitinib group because they had only been on the market so long. But there was a threefold increased risk of pulmonary embolism in being on a JAK inhibitor in this population. And the actual risk of DVT was not increased. And this peculiar phenomenon we've seen throughout this story is an increased risk of pulmonary embolism compared to DVT that can occur with the JAK inhibitor. So I think there have been some conflicting data from the French registry. They didn't see this signal. Others have seen this signal. So again, it leads to caution as we work with our patients in the clinic every day. So this was the data on major adverse cardiovascular events, which is either cardiovascular death or MI stroke or non-fatal MI, non-fatal stroke. And again, in the clinical trial program with tofacitinib, the numbers were exactly what we would expect to see with biologics in rheumatoid arthritis. However, the oral surveillance, you've all seen this slide umpteen times, read the paper in the New England Journal. Bottom line is non-inferiority was not achieved for tofacitinib for the MACE outcome. You can see that for the TNF inhibitors, the actual incidence rate was 0.73, and in the very similar trial, the ENTRACT trial, which looked at tocilizumab versus etanercept, it was interesting. With very similar design trial, enriched for cardiovascular outcomes, with etanercept, the rate was 1.7 per 100 patient years. So, I'm not sure why the differential in the studies, but nevertheless, non-inferiority was not achieved for tofacitinib. Various sub-analyses were done, and what I really want to point out here on this side here is that the number needed to treat for patients who have coronary artery disease or atherosclerotic cardiovascular disease was very low for the 2 doses of tofacitinib compared to a TNF inhibitor. So only 16 patients to harm 1 other patient. So in patients who have existing atherosclerotic cardiovascular disease, I think that's the subgroup of patients we need to be most concerned about. Shown here is in patients who have atherosclerotic cardiovascular disease versus those who don't. You can see the separation of the curves from the TNF inhibitor, which is in red, that begins almost immediately after starting on the study drug, which is quite interesting. So malignancy, when evaluating safety data and considering of starting a JAK inhibitor for a patient, which of the following factors may indicate a higher risk of developing malignancy? Female sex, older age, prior biologic DMARD use. No factors are associated with increased malignancy risk. so older age, in which we'll show you that data. Okay, so this is, again, the 23,000 patients in follow-up, and you can see numbers in a clinical trial program for the various malignancies was what we would expect with more aggressive therapies. Again, in the oral surveillance, non-inferiority was not achieved because the upper limit of confidence intervals was greater than 1.8. As you can see here down at the bottom, 2.09 for the combined tofacitinib doses. And it's interesting, in contrast to the MACE events, which separated at the beginning, in patients with atherosclerotic cardiovascular disease, there was about 18 months before the curves began to diverge, which might make you think of the latency of developing a malignancy, suggesting the signal is a real signal. Can't read this. This is great if you're looking for an eye exam and want to save some money. But the bottom line is that there was a significant difference in the number of cases of lymphoma and lung cancer, which were really driving the differential here, and also non-melanoma skin cancer in patients on tofacitinib compared to TNF inhibitors. As we already mentioned, breast cancer was seen more frequently in the patients on TNF inhibitors. It's very interesting. It's one of the sub-analyses they did. It was in the supplemental materials from that paper. And if you're less than 65, you can see that your risk of MACE and malignancy is really not much different from TNF inhibitors. So we're beginning to develop a picture of who's at highest risk for malignancy and MACE. Again, this is another regression analysis looking at a number of factors: current smokers, past smokers, over age 65. A sniff of malignancy in the past increases your risk. Again, number needed to treat over 5 years was 55 for both doses of tofacitinib. These you've all are aware of from both the EMA. The EMA updated their guidelines in 2022 to include all JAK inhibitors. And there is an ongoing study with baricitinib looking at patients over 50 and looking at cardiovascular risk factors, VTE risk factors, which will probably not read out in my lifetime, but maybe some of you younger people. So if you have a patient, 32-year-old graduate student, rheumatoid arthritis, workup shows very active disease, initial treatment with methotrexate and prednisone, difficulty stopping steroid therapy, adalimumab was added to her regimen. However, 6 months after starting adalimumab, she still is having issues. Perfect patient for a JAK inhibitor. Zero concerns. The patient I would have concerns about are the ones that we've delineated: atherosclerotic cardiovascular disease, the elderly greater than 65. I'm one of those folks. Patients who have a history of malignancy, past history of smoking, or present smoker. So takeaways: these drugs are very effective. They're not going anywhere. Their use is going to continue to expand. There are no head-to-head studies available comparing JAK efficacy, and all of the JAKs are effective. Drug retention is similar to biologics. JAK cycling is an appropriate treatment strategy in patients with lack of efficacy or intolerability. We know what our restrictions are from the FDA. As well know, avoid these drugs in people over 65 and those with significant malignancy risk factors, smoking history, or at risk for VTE. They are quite appropriate in younger patients without VTE and cardiovascular risk factors. We have no mechanistic understanding for the risk, which is really slowing us down. We need something there. A lot of people are looking at various biomarkers to try to come up with something, but so far it has not borne fruit. And we don't know if this is tofacitinib or a JAK effect. I think the agencies, by their actions, are telling us this is a class effect and not a single drug. We always put this in every talk. Shared decision-making with the patient and proper informed consent with the patient will be important in this population. So I'll stop and take a couple questions if you have them.
Stan, maybe time for one question, and then we have a whole bunch of questions for you at the panel. But do you want to comment on why filgotinib is not available in the United States?
I have no idea. So there was concerns with filgotinib on male spermatogenesis. Animal studies showed there was a problem, and they did the clinical trials. They did the studies in rheumatoid arthritis, axial spondyloarthritis, and inflammatory bowel disease. They haven't published the data, but they did have a press release, and the press release said they saw nothing in the trials. And I think they just decided it wasn't worth the effort to fight, be fourth to market in North America, but it's certainly being widely used in the rest of the world.
Okay. All right, we have more questions during the panel. Thank you, Dr. Cohen.